Welcome to our exploration of iron overload cardiomyopathy, a serious heart condition arising from the accumulation of excess iron in the heart muscle. This video will delve into the causes, effects, and management of this often overlooked disease, providing a comprehensive understanding of its impact on cardiac health. The primary culprit behind iron overload cardiomyopathy is, unsurprisingly, excessive iron in the body. This can stem from several sources. Genetic conditions like hereditary hemochromatosis disrupt iron regulation, causing the body to absorb too much iron from food. Frequent blood transfusions, often required for conditions like thalassemia or sickle cell anemia, can also lead to iron overload, as each transfusion introduces additional iron into the system. Less commonly, certain medications and dietary supplements containing high levels of iron can contribute, although this is generally less significant than the other two causes. When iron accumulates in the heart, it disrupts the normal function of cardiomyocytes, the heart muscle cells. Iron generates damaging free radicals through a process called the Fenton reaction. These free radicals cause oxidative stress, leading to cellular damage, inflammation, and ultimately fibrosis, or scarring, of the heart tissue. This fibrosis stiffens the heart muscle, impairing its ability to contract and relax effectively. As a result, the heart struggles to pump blood efficiently, leading to heart failure. The iron also interferes with the heart's electrical system, increasing the risk of arrhythmias, or irregular heartbeats. The prevalence of iron overload cardiomyopathy is difficult to pinpoint precisely, as it often goes undiagnosed or is attributed to other causes of heart failure. It is most common in individuals with underlying conditions that predispose them to iron overload, such as hereditary hemochromatosis, which affects approximately 1 in 200 to 400 individuals of Northern European descent. Patients requiring frequent blood transfusions are also at significant risk. The overall incidence is relatively rare compared to other types of cardiomyopathy, but its impact on affected individuals can be substantial. The signs and symptoms of iron overload cardiomyopathy can be subtle initially, often mimicking those of other heart conditions. Early symptoms may include fatigue, weakness, and shortness of breath, especially with exertion. As the condition progresses, individuals may experience chest pain, swelling in the legs and ankles, edema, palpitations, and an irregular heartbeat. In severe cases, it can lead to heart failure, with symptoms such as severe shortness of breath at rest, persistent coughing, and significant fluid retention. Diagnosing iron overload cardiomyopathy requires a combination of clinical evaluation and diagnostic testing. Blood tests are crucial to assess iron levels, including serum iron, ferritin, which reflects iron stores, transferrin saturation, and total iron binding capacity. Elevated levels of these markers strongly suggest iron overload. An electrocardiogram (ECG) can detect arrhythmias and other electrical abnormalities. An echocardiogram, an ultrasound of the heart, can assess the heart's size, structure, and function. Cardiac magnetic resonance imaging (MRI) is particularly valuable for visualizing iron deposits within the heart muscle and assessing the extent of damage. In some cases, a heart biopsy may be performed to directly examine the heart tissue for iron accumulation and cellular damage. Iron overload cardiomyopathy doesn't typically have distinct classifications or types beyond variations in severity and the underlying cause of the iron overload, e.g., genetic versus transfusion-related. The focus is on identifying the underlying etiology and tailoring treatment accordingly. The primary goal of treatment is to remove excess iron from the body and manage the symptoms of heart failure. Iron chelation therapy, using medications like deferoxamine, deferriprone, or deferezerox, binds to iron in the bloodstream, allowing it to be excreted in the urine or stool. This helps to reduce iron levels in the heart and other organs. In patients with transfusion-related iron overload, reducing the frequency of transfusions, when possible, is also important. Medications to manage heart failure symptoms, such as diuretics to reduce fluid retention, ACE inhibitors or ARBs to lower blood pressure and improve heart function, and beta blockers to slow the heart rate, may also be prescribed. In severe cases, a heart transplant may be considered as a last resort. Preventing iron overload cardiomyopathy primarily focuses on managing the underlying conditions that lead to iron accumulation. For individuals with hereditary hemochromatosis, early diagnosis and regular phlebotomy of blood removal can effectively prevent iron overload and its complications. For patients requiring frequent blood transfusions, iron chelation therapy should be initiated and closely monitored to prevent iron buildup. Dietary modifications, such as avoiding excessive iron-rich foods and supplements, may also be recommended, though they play a less significant role than chelation therapy and phlebotomy. The prognosis of iron overload cardiomyopathy depends on several factors, including the severity of iron overload, the extent of heart damage, and the effectiveness of treatment. Early diagnosis and aggressive iron chelation therapy can significantly improve outcomes and even reverse some of the heart damage. However, if left untreated, iron overload cardiomyopathy can lead to progressive heart failure, arrhythmias, and sudden cardiac death. Recent research has focused on developing more effective iron chelators and improving cardiac imaging techniques for early detection. Studies are also investigating the potential role of gene therapy for hereditary hemochromatosis. Ongoing research promises to further improve the management and outcomes for individuals with this challenging condition.